let's dive in. Diabetes, it's one of the most complex and honestly fascinating conditions when you really break it down. So, at its core, diabetes is a chronic metabolic disorder. The big hallmark here? Persistent high blood glucose levels. And it's caused by these glitches in insulin secretion, action, or even both. It's, it's everywhere, right?
Absolutely. We see this condition impacting not just blood sugar levels, but entire organ systems. And there's a vast difference in why type 1 and type 2 diabetes occur. One's primarily autoimmune, and the other is, well, a very different beast, often tied to resistance to insulin and environmental factors.
Yes, exactly. And it's critical to get that distinction right because the treatment strategies are, like night and day. Speaking of distinctions, let's start with type 1.
Right? T1D is, as you said, autoimmune. The body's own immune system attacks those beta cells in the pancreas. And it's brutal because these cells are the ones responsible for producing insulin. Once they're gone, you're looking at total insulin dependency.
And that autoimmune destruction, it doesn't happen overnight though,
No,
does
it's
it?
progressive. It begins with what we call a genetic predisposition. Certain triggers, maybe viral infections, can set off the immune system, and then we see a cascade that leads to beta cell loss. Unfortunately, by the time symptoms appear, most of the beta cells, somewhere around 90%, are already destroyed.
And what you'll really notice in patients, especially younger ones, is how suddenly the symptoms can seem to appear. We're talking frequent urination, excessive thirst, like polyuria and polydipsia, massive hunger, but at the same time, they're losing weight like crazy.
Yes, which often leads to a diagnosis during a crisis like diabetic ketoacidosis or DKA. It's severe. And tests for type 1 often include looking for autoantibodies or checking C peptide levels to confirm the complete insulin deficiency.
Right? But then you flip it around with type 2 diabetes, T2D, and the story changes entirely. This one's much more of a slow burn.
It really is. With type 2, the body's tissues become resistant to insulin, so glucose can't effectively enter the cells. And to compensate, the pancreas tries to work overtime, pumping out more insulin.
Until it just, gives out. And then boom, long-term high blood glucose levels set in. Obesity and inactivity are major culprits here, right? The numbers say it all.
They do. Diagnostic criteria include things like HbA1c levels above 6.5%, fasting plasma glucose greater than 7 millimoles per litre, and using the oral glucose tolerance test. And what makes type 2 so challenging?
It's often asymptomatic for years.
Exactly. A lot of patients don't know till they start experiencing complications. That's why regular screening in at risk populations is critical. We cannot emphasize that enough.
So many layers to this disease, Ethan, and we're only just scratching the surface here. And yeah, this is just the beginning. So, with all that complexity in mind, let's hone in on one of the most vital tools for managing diabetes, insulin. It really is the cornerstone for type 1 diabetes management, right? Its role in facilitating glucose uptake into cells simply cannot be overstated.
Precisely. Insulin acts like a key, opening doors for glucose to enter cells where it's used for energy. Without it, glucose lingers in the bloodstream, leading to hyperglycemia. Now, the types of insulin we use vary: rapid, short, intermediate, and long acting, all tailored to patient needs.
But let's not sugarcoat it. Insulin therapy has its challenges. Hypoglycemia, anyone?
Absolutely. Hypoglycemia is perhaps the most concerning complication. Imagine this: a nurse managing a patient who's unconscious due to severe hypoglycemia caused by skipped meals after insulin administration. Quick action is key. Fast acting glucose if they're conscious, or glucagon if they're not. And continuous education on proper insulin timing and nutrition is critical.
It's all about staying a step ahead. Okay, moving over to type 2 diabetes. Oral meds, the big guns of pharmacotherapeutics. Metformin, That's the frontliner, right?
Exactly. Metformin works by reducing hepatic glucose production. It activates AMPK, a cellular energy sensor, which cuts down glucose production and enhances insulin sensitivity. It's effective, but as nurses, we monitor for side effects. GI discomfort is common early on, and don't forget monitoring for B12 deficiency over time.
And then you've got sulfonylureas. These are like insulin secretagogues, right? Stimulating those beta cells to pump out more insulin.
Exactly. They act on ATP sensitive potassium channels in beta cells, triggering insulin release. But here's a catch: they carry a higher risk of hypoglycemia compared to metformin. For patients with irregular eating habits, extra care is essential to avoid dangerous glucose drops.
And the newer stuff like GLP-1 receptor agonists. To me, these are game changers. They mimic the incretin effect, slowing gastric emptying, reducing appetite, and even promoting weight loss. Am I right?
You are. GLP-1 receptor agonists, DPP-4 inhibitors, and SGLT2 inhibitors really shine in tailored treatments. Take SGLT2 inhibitors, for example. They promote glucose excretion through the kidneys. It's brilliant, but they can increase risk of UTIs or dehydration, so patient education on hydration is critical.
And here lies the challenge: fine-tuning these treatments. You've got efficacy, side effects, lifestyle factors, and cost all stacked up. In a rural setting, for instance, limited access or affordability could really sway the therapeutic choice, right?
Exactly, Yenna. Think of a patient in a remote area managing type 2 diabetes with limited resources. Metformin might be a great first-line option due to its low cost and minimal risk of hypoglycemia. But adjustments become crucial if complications or contraindications arise.
Oh, it's a delicate balancing act, that's for sure. And this, I think, is where nurses shine, bridging those gaps through education, monitoring, and empathy.
Exactly. And these considerations are foundational to effective diabetes management. But of course, pharmacotherapy is just one piece of the puzzle.
Pharmacotherapy is critical, Ethan, but as you said, it's just one piece of the puzzle. Let's delve into the other cornerstone: lifestyle choices like diet and exercise. Would you agree it's the real foundation of effective diabetes management?
Absolutely. No amount of medication can fully compensate if these elements aren't addressed. Take diet, for example, focusing on a low glycemic index. It's critical for keeping blood glucose stable. Foods like whole grains, legumes, and leafy greens are great examples.
But portion control, Ethan. I mean, I've seen people pile up their plates with healthy foods, not realizing carbs are carbs, right? Even sweet potatoes can sneak up on you if you're not watching portions.
Exactly, Yenna. Balancing macronutrients is key. Pairing carbs with protein or healthy fat slows glucose absorption and minimizes spikes. And hydration plays a part too. Plenty of water helps with overall metabolic balance.
Now, you know I can't not talk about exercise here. The smallest changes, like walking for 30 minutes a day, can improve insulin sensitivity, yeah?
Absolutely. Aerobic exercise like walking or swimming combined with resistance training show great results. Resistance bands or light weights can help build muscle, and increased muscle mass means better glucose uptake. Win-win.
It's so true. I had a patient, a busy mum, who started doing just 5 squats after every hour of work. It was micro, but in 3 months, her HbA1c improved significantly. I mean, how inspiring is that?
That's fantastic. And patient education ties all this together, doesn't it? When patients understand the why behind all these recommendations, they're more likely to stick with them. Take nurse-led education programs.
Oh, they're life-changing, Ethan. I saw this one program where they taught patients how to meal prep and even grocery shop effectively. Not only did HbA1c levels drop, but hospitalization rates plummeted too.
And the follow-ups. Regular check-ins help prevent complications because they catch small issues early. A supportive relationship between the patient and healthcare provider can make all the difference.
Absolutely. It really boils down to teamwork. Healthcare providers, patients, and families all rowing the same boat. And with diabetes, proactive care changes lives.
On that note, I think we've covered a lot today. Yenna, from understanding the condition itself to pharmacotherapy and lifestyle strategies, there's so much that goes into effective diabetes management.
Absolutely, Ethan. And for everyone listening, remember, knowledge is power. Empower yourselves, empower your patients, and take that knowledge into your practice. We'd love to hear your thoughts or questions, so keep the conversation going.
And thank you for joining us on this deep dive into a critical topic. Until next time, take care, stay curious, and keep learning.
Bye for now.